Hello and welcome everyone to Final Fridays with the John Ritter Foundation for Aortic Health. We are very happy to have you all here today, and especially to be joined by a wonderful expert in aortic surgery. So to start us off, just to let you all know, this is going to be recorded and it will be available for viewing later. If you have questions, please go ahead and put those in the chat and we will try to answer as many as we can. I also do have the questions that you all sent in when you registered for the event, so we'll be trying to address some of those as well. And I think that's all of our housekeeping, so I'm going to introduce Amy Yazbeck, who is the founder and chairman of the John Ritter Foundation.
Hello, everybody. Welcome to this amazing thing we do. We may have a couple technical challenges on the way because welcome to the new age, as they say. I think that's Imagine Dragons. I'm introducing today a wonderful person who I could say many, many lovely personal accolades about, but I'm going to read his bio because it's crazy. Dr. Estrera is a professor in the Department of Cardiothoracic and Vascular Surgery, cardiothoracic surgery at the McGovern Medical School of the University of Texas Health Science Center at Houston, also known as UT Health. He is a faculty, listen to this, he is a faculty member of many interacting medical facilities at UT Health. He is also the chief, he's the chief of cardiac surgery and director of the cardiovascular intensive care unit at the Heart and Vascular, it doesn't say cardiovascular, I like it saying Heart and Vascular Institute, Memorial Hermann Hospital at Texas Medical Center. Dr. Estrera specializes in diseases of the aorta, hence he's here, specifically focused on thoraco-abdominal aortic aneurysms and aortic dissections. And if you don't know the difference between an aneurysm and dissection, he'll be getting to it. People get confused about that all the time. Dr. Estrera has been a key part in building the Department of Cardiovascular Surgical Services at UT Health. Had co-authored 35 chapter books. Boy, we might not have time for your entire intro, but for us, his studies have led to refinements in surgical techniques for the treatment of thoracic aortic aneurysms and aortic dissection. Collaborates with Dr. Diana Milowitz, our John Ritter Research Program in Aortic and Vascular Diseases, the boss there, and their combined efforts, I love him very much. Their combined efforts have led to the identification of multiple genes associated with the etiology of thoracic aortic aneurysm and dissection. So this is our guy. And he was the first person that I guess I reached out to him and he reached out to me at the same time. He explained the world of thoracic aortic dissections and aneurysms to me over, I believe it was a tuna fish sandwich at a hotel called Shutters, and started this whole thing. And without that first influx of the medical community, which came from him, being so not just supportive, but welcoming for me, there's no way I could have started this foundation, because I was scared of doctors for a minute there, and now I love them, starting with Tony. Dr. Estrera, take it away.
Thank you very much, Amy. I really appreciate that introduction.
Yeah, I'm crazy about you.
I also thank Ellen for hosting this. But it was almost 20 years ago that we met because of all this, if you really think about it. And it was a tremendous honor to be invited to this session, Back to Basics. So with that, we all know John Ritter, a comedic genius, a great father, a better husband, and just a genuine good person from everyone I've ever spoken to about him. And he was also stricken by thoracic aortic dissection and unfortunately died from that. He was taken from all of us too early. But no one has done more to increase the awareness of thoracic aortic dissections and aneurysms than really Amy Yazbeck has done. And this has become passion over the past 20 years, really 19 years, in increasing, the awareness about this disorder and disease, so that what happened to her husband won't happen to others in the future. And this ultimately led to the creation of the John Ritter Foundation, which she's the CEO, chairman, director, really the impetus behind this whole project. And
Tony,
this effort.
I'm not the
Yeah.
CEO. Meredith Ford O'Neill is the CEO. Thank goodness. My talents lie elsewhere. I'm the founder and the chairman of the board. Go on.
You're welcome.
Okay.
I apologize. Not the CEO, but anyway, she's done a great job with regards to this and increasing awareness, and they have a number of great projects ongoing as the momentum has taken off with regards to this organization in general. But you have to remember, the purpose is really preventing unnecessary suffering because of the unknown, to make thoracic aortic dissection a routine part of the doctor and patient conversation, and the mission is to raise awareness of thoracic aortic aneurysms and dissection through research, education, and advocacy. And she's partnered with Diana Milowitz, who I'll make some comments later on, who's here at UT Health, and they've done a great job in increasing, that research concepts through, science and improving the awareness of dissections and aneurysms. So with that, this is back to basics. So I'd like to just talk a little bit about terminology. Dr. Leftaudis from Yale did this similar session a few weeks ago and did an outstanding job. And he had his perspectives, and I'm sort of going to give you my perspectives on the basics. But it's real important to know what the aorta is. I think of the aorta as the main pipe of the body, comes out of the heart, arises from the heart, the ascending aorta to the transverse arch, as you can see there, down the middle of the back to the descending, and then the abdominal aorta. And the descending and abdominal is considered the thoracoabdominal aorta. I mentioned these diameters here because these are quote unquote normal. And I say quote unquote because they do differ depending on your size, height, sex, in general. But this becomes very important when we talk about what an aneurysm is. So we'll hear the term enlargement, ectasia, dilatation. In all, these are all differing types or terms that we use for aneurysm. But remember, an aneurysm is when the aorta dilates more than twice or more than 50% its diameter, and we usually intervene when it gets to about twice the diameter. So that's why those baseline values become important. But you'll hear physicians talk about enlargement, again, ectasia and dilatation. They're all forms of aneurysms in general, and you just have to keep that in mind. I must say that I am a surgeon. I will show some pictures. I apologize, but no videos regarding surgeries. But I do want you to see what some of these things look like. And the head's at the top, the legs are towards the bottom, the heart's pictured more towards the right, and then you see this big ball in the middle of the chest, and that's an aneurysm. That's a ballooning out of the ascending and aortic root of this patient. Now, you'll hear the term dissection. That's when a tear occurs. Now, remember, the wall of the aorta is made up of multiple layers, concentric layers. And when you get a defect or tear in that wall, which is weakened for whatever reason, then you can get blood flow that can split the wall in half, in theory, creating a true and a false lumen. Now, I had a video here, but I'll show you this picture because I know Amy likes food, and I know with the last
this is better than the animation.
back to the basics. They talked about hot dogs and sausages and things like that. But honestly, I haven't had this, Amy. This is someone sent me this slide, but it actually does depict what a dissection does look like in cross section.
That's amazing.
And so Lay's has to be credited. And the reality is how they make these chips probably is similar to what happens with dissection. As you can see, the flap, the inner wall or flap, the false lumen, the true lumen, and the outer wall. But you can imagine with dissection, when this dissection occurs, that outer wall becomes weakened and makes it at risk for forming a larger aneurysm. So
the example you showed would be what a cross section of the tube would look like when one of the layers has been kind of torn into and filled up, so it like pushes into the middle. Okay, all right, this is amazing. Let me get a phone call into Frito-Lay immediately.
That's exactly right. And
Cool.
again, I haven't had these yet, so I'm going to have to try it. But anyway, this is sort of what happens with the tear on the inner side, and you can see the inner wall torn, and then there's a false channel outside of that, and then the outside layer is also pictured in this patient with an ascending or type A dissection. This is just a general picture of what the aorta looks like. Again, it comes out of the heart, and the aortic root houses the coronary arteries and the aortic valve, leading to the ascending aorta. Remember, aneurysms and dissections. Dissections can occur without aneurysms, but remember that that's pretty rare. There's usually a predisposing aneurysm present when the dissection occurs. Also remember that aneurysms can occur with dissection. Once the aneurysm dissects, it can form a larger aneurysm with what we call chronic dissection, depending on how long that flap's been there. But you have to remember that it depends on the location, and this should have been animated, but the infrarenal abdominal aorta is usually associated with aneurysms, and that's going to be the most common location for an aortic aneurysm, usually 5, 6, 7 to 1 compared to the other locations. Then that's followed by the ascending aorta or proximal aorta, and that's where a lot of these type A dissections occur, and that's usually more associated with dissection, although we will operate on a lot of aneurysms before they dissect. And then the distal descending and thoracoabdominal aorta has aneurysms, as well as dissection, and about 50-50. You'll see a lot of the aneurysms before they dissect in this location. But you can see, depending on the location, will determine the risk for whether you're going to have a dissection more frequently than an actual aneurysm.
Wow.
So the problem with dissection too, aside from rupture with an enlarging aneurysm, is that dissection with that flap, if you can imagine that flap can cut off or block off vessels. And remember, the aorta, the largest main pipe of the body, has a number of branches that come off of it that supply all our vital organs, brain being probably one of the most important. But you have the heart, the spinal cord, the gut and renal vessels, and then also the lower extremities. So anytime a dissection occurs, it can block off the flow to any of your vital organs, causing major problems. So Amy remembered, obviously John's show, 8 Simple Rules, and in that, trying to increase awareness with regards to aortic dissection, she developed really the Ritter Rules. And these Ritter Rules were sort of a set of rules that could apply to every situation, apply to every physician, but most importantly, when these patients would present with chest pain or back pain to the emergency center. And it really talks about, some of the main concepts about aortic dissection. Now, again, these Ritter Rules were developed a number of years ago by Amy Yazbeck, and the reality is I'd like to, for the main course of my presentation, talk about Ritter Rules for surgery, specifically addressing, what is important with regards to thoracic aneurysms and dissection and surgery. And this will really be focused and applied to, what the everyday patient who has to deal with this would want to know. So, number one, acceptance that aortic dissection really is a lifelong condition once you have it. And having an aneurysm in general is something also that needs to be followed. It's a long road, a long path ahead of one who does have ultimately a dissection. And it doesn't start or end with surgery. Although we think of surgery as an end result, a lot of times now we're appreciating the benefits of doing early surgery to prevent the complications of dissection, as you can imagine, rupture, death, and redissection. So with that, our goals of management of patients with aneurysms is really to prevent dissection, which can lead to rupture and ultimately death. And we must remember that. So again, the goal is to prevent dissection. And with that, what's the natural history really of the dissected aorta? These are scientific numbers, and these are from studies of all comers, even the patients who obviously do poorly, who don't have good follow-up. But I don't want to scare you, but the reality is the 5-year survival in patients who do develop dissection can be as low as 50%, and as high as 80 to 90%, depending on, the studies you look at. So we do know that it can affect your late survival if you do develop a dissection, but that can be mitigated by a number of things we'll be talking about in just a moment. The late reintervention rate, meaning needing a procedure, a surgery later on once you've developed a dissection, falls between about 10 to 25%. But if you have a genetic disorder, Marfan's disease, Loeys-Dietz, ACTA2, all these can increase your risk of requiring an intervention later on. So you have to keep that in mind. And in general, the aorta can grow or will grow a certain small percentage, small amount every year. And that's what's expected around, 0.8 to 1 millimeter per year in general. Now, Dr. Leftatis developed this sort of concept a number of years ago, about 30 years ago, that helped guided us, surgeons, physicians, on when to recommend an intervention. The red line shows the location of the descending, remember the distal or descending thoracic aorta, and that hinge point where complications occurred, which included dissection, rupture, or death, was around 7 centimeters. And then on the ascending, it was around 6 centimeters. And so the reality, the guidelines for recommending surgery then were developed at around 6 for the descending and around 5.5 for the ascending. And that's where these numbers ultimately came from. But we have to remember, when people dissect, the reality is many patients will have aortas smaller than that 5 to 5.5 diameter. And this was a nice paper out of a group that included the Penn group as well as the German group, that showed that as much as 32% increase in the diameter can occur when a patient dissects. So they actually had the CAT scans before patients dissected and then measured them right after they dissected and noted that there's a 30% increase in the diameter. So the reality is that dissection likely occurs at smaller diameters than what we are thinking about for surgery. Now, surveillance prevents complications and improves survival. I think that's a very important part, or very important concept, and that's why it's important to have continued follow-up if you have a thoracic aneurysm or have developed dissection. Even if you've been repaired, there is still that risk for downstream or distal aortic problems. And so the surveillance, although I'm pretty aggressive early on an annual basis, is really a CAT scan or MRI and an echocardiogram. Remember, the echocardiogram can look at the heart and the proximal or the ascending and aortic root of the aorta very well, but it doesn't see the rest of it. So that's why if you want to know what's going on with the rest of the aorta, the downstream aorta, you need either an MRI or a CAT scan. And I know there was a lot of discussion on the last office hours about this topic. which I would refer you to listen to that conversation with Amy and Dr. Lefteadis and Ellen on that session a few weeks ago. But again, remembering that all this in general is to try to prevent dissection from happening, because once it happens, it does affect your natural history. And so this is basically what I talk to with my patients when I'm talking to them about surveillance. So these are patients who have either had a dissection or patients who I'm just following who just have a small aneurysm, and what I guide them or counsel them, to say. So number one is really blood pressure. It's important to maintain a good blood pressure and have your cardiologist or primary care doctor manage this. I do recommend that all the patients who are being followed purchase one of those blood pressure machines that you check on a regular basis. Always check the second number, because the first number is always higher than the second number, and always check it at least twice when you're checking your blood pressure. Now,
Dr. Estrera, are you avoiding pronouncing what that's called?
Yeah, pretty much.
Sphygmomanometer.
Yes.
Sphygmometer. How do you say it? Just tell me.
I just call it blood pressure machine.
God darn it. Okay. Go ahead. Trying to trip you up. I apologize, everybody.
It's okay. And so, I'm gonna tell a little anecdote here on the optimal medical management, going back a really number of years ago. And I don't know if you knew this, Amy or Ellen, but it really goes back to turkeys. And so we think about beta blockers, but there was actually a paper back in the early 50s, a veterinarian paper out of Canada, in which they identified that these turkeys in the turkey farms up there, when a plane would fly over, startle them, a number of turkeys would actually die. And they actually studied these turkeys, and they would actually have aortic dissection of their abdominal aorta. So then later on that decade, in the late 1960s, 1950s, there was actually a study where they actually treated turkeys with reserpine, which is a medication to decrease that impulse therapy or that force, contractile force of the heart. And by doing that, they actually salvage or improve their crop numbers with regards to their turkeys. So that's how this whole concept really arose. And then Myron Wheat in the 1960s applied this to patients, and at the time noted that patients who were treated with medications, specifically reserpine, to reduce that contractile force would actually improve or had good early outcomes. And this ultimately led to work that was done out at Stanford and the use of beta blockers to try to reduce the progression of and propagation of dissection and rupture in these patients. So that was very important developments back then. But as Dr. Lefteadis and you noted at one of the prior Back to Basics, I mean, he is right that it's important to have these medications on to control your blood pressure, but there's no blood pressure medication. There's no medication currently that actually makes these things shrink. We're using these medications to prevent the propagation or the development of complications of dissection or aneurysm. So you have to keep that in mind. And I do think beta blockers are important because it does reduce that impulse force as opposed to just dropping the blood pressure. The whole concept here is to reduce that impulse force of the heart and its contractile force. So with that, other things that I talk about patients with is really activity. There'll be some comments in just a little bit that I make about activity, but I think the main thing about activity that I counsel the patients is to avoid that Valsalva maneuver. What's that? That's where you're like lifting 100-pound bag of dirt or something, and you're really straining down for a prolonged period of time. That's what you want to avoid, that sensation. So obviously it's hard to put a weight limit on folks because everyone's different. And you may have a real big guy who can lift 50 pounds without any issue. I have no issue with that. But if you're having to strain a lot to do something, I would recommend avoiding that. Smoking, I tell the patients to avoid smoking because Smoking has been shown to cause problems with aneurysms in the infrarenal down the aorta. Constipation is the same concept of activity. You want to keep regular because you don't want to strain on the toilet. One of the first known episodes in King Edward was constipation leading to dissection in him who was using the bathroom. Sleep breathing disorders like sleep apnea. If someone snores, it's considered, and they have issues where they stop breathing at nighttime, we call that sleep apnea. And when that occurs, you can increase your intrathoracic pressure, at nighttime when you're sleeping, which can cause worsening or enlargement of your aorta. And there's some new research coming out related to that. The other new item, relatively new item, is fluoroquinolone antibiotics, or Cipro, a very common antibiotic used for urinary tract infections. That antibiotic has been shown, or that class of antibiotics has been shown to be associated with complications related to dissection and rupture, both in animals and population-based studies. And so there is now a black box warning on the medication profile for fluoroquinolones if you have a known aneurysm. And genetics is the last concept here, which really relates to a lot of the work that Dinah Milowitz has done over the years to identify which patients are at risk. John Leftatis had a very nice analogy as to, our genetic code is like 2 billion grains of sand on a beach, and having one change in a letter can lead to aneurysmal dilatation, which is so true. And this is sort of a lot of the work that investigators like Diana have been able to identify some of these defects, which become very important in how we manage these patients. But remember that 20% of all thoracic aortic aneurysms dissection have a genetic connection. So that family history becomes very important when you do identify these patients. A prime example is John Ritter. I bring this example up because Zoe on the left was a high school student, and the mother on the right was found or determined or found by Dr. Dinah Milowitz when, unfortunately, tragically, her husband was 35 at the time, died of dissection, and she had 2 brothers who both died of dissection. And they ultimately ended up with Dr. Dinah Milowitz, who identified a PRKG1 defect, a single mutation that led to this aortopathy. And if you look at, these are notes from my operative note on this case, and her aorta was only 3.55 centimeters, so it's not very big. So you could argue she didn't need an operation. But, in this case, it's very difficult for any of us to sit here and see what that mother went through with the rest of her family. And I liken this story to Saving Private Ryan. When Saving Private Ryan lost all the 3 brothers, everyone in the government did everything they could to get him back home so he wouldn't die. And this is the same concept in my mind. And this becomes very important because that single genetic defect identified a certain pathology that led us to do a prophylactic operation on her. And that operation was an ascending aortic root replacement where we actually saved her valve. That's another advantage of doing these operations sooner, because as the aneurysm gets bigger in the root, the ascending root area, it can stretch that valve out and damage it. And so if you can get to it sooner, you can actually save that valve, so the person is not relegated to Coumadin with a mechanical valve or complications of any kind of artificial valve that they have once that has to be replaced. So if you can get to it soon enough, then that's a big advantage for a patient's long-term survival and quality of life. And so that becomes very important. I mentioned here anxiety. John Leftatis showed this slide last time showing emotional stress. I do think this plays a very important part, both as a trigger for dissection, but also the anxiety of knowing an aneurysm is present in someone can affect their quality of life. And there's some studies ongoing right now about how this affects a person's quality of life. But I use this as another factor in how I decide whether to do an operation or not when I counsel the patient. Surgery is important because if you can do it soon enough before a complication occurs, you can actually affect their long-term survival. This slide becomes very important here because it shows that patients with aortic root replacement almost have an equal long-term survival as the age and sex match group in the US. So it becomes very important. Number 2, prepare electively for surgery first. It's really balancing surgery versus watchful waiting. Remember, elective surgery carries a 1 to 2% mortality. Emergent surgery, 20 to 50% mortality. So we want to do this before it becomes a problem. And remember, surgery really is a big deal. It's a lot to go through, but who do we operate on? We have to make decisions about that because it depends on their comorbidities. There are a lot of potential risk that can occur. Dr. DeBakey here, you may or may not know who he was. He died a number of years ago, but he lived to 99. He was the founder of Baylor College of Medicine across the street here in Houston, and actually did the first dissection operation back in the 1950s.
Tony, you introduced me to him.
Yes, Dr. DeBakey and Dr. Stappy there to the right, to my right, and then Becky Lenton, who is Dr. DeBakey's nurse. They came to visit us a number of years ago before obviously he passed away. But this is after he had his dissection repair. And this is just another example that age may not necessarily be a contraindication. I mean, you're here to save lives. This was a 90-year-old that we had operated on. They did a little story on him because he was a writer. But electively, you want to really take care of yourself and prepare yourself mentally as if you're training for a marathon, is the way I explain it to our patients. And I'm sort of stuck there. Oh, you split it in 2. Okay.
Yeah, sorry. So you should be able to do part 2. It was just too large of a file. You had too much info to share.
We're going to run a little bit over.
No file
shaming. So I'm going to show this
now
video.
It's time to start preparing and getting myself ready.
I think this is important too, as for patients, because this person is Keith Isbell, who had an aneurysm repaired in 2015, and he actually created these videos that are on YouTube that really outline what he went through. And I have some snippets here for a couple of minutes just to show you.
For surgery.
And there's a whole bunch. That went into this at the time, or at least it felt like there was a lot that was going on. Because my situation was different. This was not an emergency open heart surgery. My open heart surgery was scheduled. And in fact, from the day that I met the doctor, I had 3 weeks. So I knew there were some things that were going to be important. I had an opportunity to change my diet. And I mean really change my diet. And lost almost 20 pounds. And it was a good 20 pounds. And my body was probably in the best shape that it had been in going into that surgery. There was an exercise regimen, not once, not twice, but 3 times a day that I would do. But one of the things that I did is I would go to YouTube and I would watch videos of other guys and gals that had gone through the same type of surgeries. Open heart. I guess I don't know, not exactly like mine, but had gone through that. And I watched them. And I watched how they had to get out of bed. And I watched how they had to manage their breathing. And I watched as much as I could, and I made notes. And I'm so glad that I did this because, and I would say to you, the one thing that really was a big deal was I watched one of the guys that had just come out of open heart surgery in ICU, and he couldn't talk. Obviously, there's, most can't. But it made me think, what if I wouldn't be able to talk for days? I needed to have a sign with my hands, just a key, and I did. For my wife, I made a key with hand signs, not just for yes and no, but just about everything. And actually, when I woke up, and I don't even remember this, is that I gave the sign 2 signs. I gave one to be able to write, and I was able to scribble some stuff for my wife. And the other was I asked for water. Trust me when I tell you, you will be incredibly thirsty.
So I think these videos were very helpful because he really outlined what he went through. And I thought that was very helpful for a lot of my patients. So because there's not a lot of resources. And I now refer all my patients to the John Ritter Foundation website if they want to share their stories, because I do think that's important. And we'll get to that in just a moment. Number 3, understand proximal versus distal. I've sort of outlined this already with regards to this section classification. And remember that type A or DeBakey type 1 requires surgery, and anything in the back or type B will usually be medically treated initially. And then now with the advent of stent grafting, I think that has some advantages in terms of the long-term outcomes with regards to even type B dissection. Remember that 2/3 of the sections are all type A and 1/3 are type B, and a majority of type B will be quote unquote uncomplicated initially, but will develop or can develop complications down the line. Proximal is really talking about the ascending aortic root, and distal, that requires a median sternotomy for treatment. And the distal, again, the proximal is sternotomy, usually requires the bypass machine, whereas the distal is a thoracotomy type incision if you're not going to get endovascular, and that requires sometimes partial bypass with a lot of the techniques that we've developed over the years to treat these aneurysms. It's important to understand open and endovascular are tools. They're not competitive. I think they're complementary as the technology has advanced, especially in the endovascular arena. The endovascular revolution is here to stay. It started really in the early 2000s. Dr. Dake is from Stanford. Dr. Prodi developed the first infrarenal stent graft. But the role of stent graft really is primarily in the infrarenal. Most infrarenal conditions are treated with stent grafts. The descending and thoracoabdominal are now more and more being treated with stent grafts. And the ascending is still limited to really very, very high risk or complications, but open repair primarily treats the ascending aorta. Now, there is a changing landscape with a shift in shift towards endovascular treatment. But again, I want to emphasize that they're not competitive. They're really complementary. And it's important when you pick a center that they have options of both and expertise in both, because there is much more advancements in complex endovascular repairs, although many of these may not be applicable to especially patients with connective tissue disorders. But I do use this individualized standard for aneurysm treatment that really takes into consideration frailty, life expectancy, anatomy, and pathology. And depending on these situations for the patient, we'll sort of lean towards one type of repair versus the other. And sometimes patients are too sick to be operated on, although we try to offer them, something if at all possible. So 5, select hospitals that are familiar with aortic surgery. I think this is very important in seeking care for aortic disease, that you do have a designated and dedicated team. There are a number of good centers out there across this country, but that aortic team also includes all these other aspects with regards to the comprehensive treatment of patients with aortic disease. Hybrid suite to do endovascular becomes a very important tool for us. And we do have multidisciplinary conferences in which we discuss the genetic disorders, especially, as well as surgical aortic conference to discuss every case that comes to this board. And then a number of organizations are here that can give ideas about what's good for patients in general. And so what about the surgeon? Really, surgeons' expertise comes from experience, and it's really all about the team. There are a lot of very good surgeons out there, and I think as important, if not more important, is making sure that there's a good support team around the surgeon when you're doing these cases or caring for these patients. I think it's important for patients to appreciate the risk and benefits. Remember that there's early and late complications, and that in general, the proximal aorta has complications related to the heart, the lungs, and neurological complications like stroke, whereas the distal descending and thoracoabdominal have kidney issues, and paraplegia is always a devastating risk related to this disorder or these issues. Number 7, really inquire what to expect after surgery. I think that's very important, and to talk with your physicians. There's issues with pain, there's subtle changes. Medications will change for the first 6 weeks after surgery. You won't have an appetite. You will actually lose weight after you gain weight from water changes in the initial few days. I always counsel the patients that these large operations, they'll lose at least 10 to 15 pounds, and then as their appetite improves, they'll get that back. Bowel movements and GI tract take time to recover, and it really takes 2 to 3 months until you really feel back to normal, after these operations. And those are the expectations that it's important for you to understand when you're undergoing these very large operations. I do believe it's important to be active without overdoing it, both before surgery and after surgery. There's some data here to suggest what are high-risk activities, but in the end, there's really isn't a lot of really good data to suggest what's best for patients with aneurysm. So that's why I always counsel the patient just to avoid that heavy straining, that what we call Valsalva Maneuver. And it really depends on the strength of the patient and what activities they do. But I never discourage walking, jogging, even swimming or bicycling, because you want to gain your life back. And with regards to personal relationships, I have no issue, with that, just as long as, things are done within reason. I'll just keep it at that for now. But, empower yourself as a patient. You really ask questions, because no one's going to really look out for you better than you yourself. So keep a notebook. Take lots of notes, make lists of questions, and make sure you feel comfortable with your surgeon and your team when you're talking about having surgery. And so share your story. I think that becomes important, because there's a lot of patients out there who don't know what to expect. And that's one of the biggest questions I get, as a physician caring for these patients is what do I need to expect after a procedure like this? And I think the more information we can give a patient, and the more information they can seek out and learn about what to expect, the easier it is going to be for them to recover from these very, very large operations. And so the Houston Aortic Symposium was really one of the first forums for us here in Houston, in which Amy had spoken and really shared her story and her challenges with dealing with John and his death. And so really it's all about the patient, in my mind. And we have forums where we have patients come together. Shireen Shalhoub has done a good job and has some NIH funding in which she's doing this at a larger scale for type B aortic dissection patients. There's a lot of websites available to share, experiences. And obviously the Faces of Thoracic Aortic Dissection is on the John Ritter Foundation for Aortic Health website. But again, it's really all about the patient. And I go back to Keith Isbell, who was a patient of mine back in 2015, and he has these videos online, which I'll share you a few minutes with one of them. He got through the surgery very well in the end and was very inspirational, but he actually died in 2019 of head and neck cancer. So after he went through everything that he went through with regards to his aneurysm and valve, and what I dealt with him, he then developed head and neck cancer and ultimately died from that in 2019. We were sharing a little video story on his aneurysm and ultimately later cancer on this news program here. But these are some of his videos, and I will share a little bit of the last video that he had.
And you finally get home. And this is what I didn't see, at least on YouTube. I couldn't really get a lot of information from, even from the hospitals. I mean, it was there. But from a patient's perspective, this is the meat of it. And I will tell you that the day that I got home, which of course was great because I was home and I got to be in my own bed and all of that, but then it was getting out of bed. You know, it would be very, very easy to just settle in, but that's not what you're supposed to do. And that day that I got up, wandering around with my pillow, you'll get to appreciate the pillow, and I wandered around with my pillow, and I kept thinking of all the things that I couldn't do, the number of restrictions, if not the thousands of restrictions that I couldn't do, and there were many, many of them, and that was the initial moment where I really felt like, oh my goodness, this is going to be really heavy. And I can see where things like depression that they'll talk about can come very, very quickly. But what I did in that moment is I went to my office and I sat down and I wrote down 7 things that I could do. And I wrote down and I said, take a shower, do the laundry, walk, and I could eat, and on and on. But I had this little short list of things that I could do, goals, I guess. And that day, I put my shoes on when I didn't want to get out of bed. It was my first day there with my pillow, and I wandered out the front door, and I walked for 3 miles. When I got into week 3 and week 4 again, walking every single day. I made it a point to walk 2, sometimes 3 times. And you know your body. And you have to be able to trust what it is that you feel. Listen to your doctors. Do what they say and tell you, if they're telling you don't lift more than 20 pounds, then don't do that. If you feel like your body can do a little bit more, I know at least for me, I wanted to push that a little bit. And in all of this, I was eyeing up week 8, 2 months after my surgery. So I think it was September. My wife had made an appointment, a reservation for us to go to Disney. And when all this started with everything, that didn't look like it was going to happen. But I kept saying, do not cancel that reservation. And even after the stroke, it was like, there's no way we're going to be able to do this. Well, you know what? The stroke is what gave me a surgery date. Well, the surgery date gave me a starting point. That starting point 8 weeks later was exactly the moment that we were supposed to have the reservation to Disney, and I said, don't cancel it. Those were the goals. And by the time I got to week 12, I wanted to bench press 100 pounds, and I did. You have to get your attitude completely right. The other part that I would say is, and it's very important, is just goals. The goals that you've got to have, because that's what gives us purpose. And the goals need to be realistic. You need to be able to challenge yourself, and you need to be able to push yourself, but you got to have goals that you can cross off of a list every single day. Combine that with the attitude, and I got news for you, you win. And you start picking up victories. The more wins you get, the more victories you get, the better you start to feel, and the more that you can do. Get your attitude right, get your approach right, get your position in all of that correct, set your goals, have your purpose, and go win. Good news is you're in control of yourself.
So these are some of those videos on YouTube, and I guess you can get those later on. But in the end, these are my Ritter's rules for surgery, and they're all very important. They're, in my opinion, all centered around the patient, which is why we all do this. And in the end, as a patient, you want to be able to control your life, and you don't want to let thoracic aortic aneurysms and endossection control you. So with that, I want to thank you for the opportunity to share, my ideas and concepts with regards to back to basics for the John Ritter Foundation. Thank you very much, Amy and Ellen.
Thank you.
Thank you. That was wonderful. I love the rules for surgery. That is fantastic. And we will get those YouTube links, and we'll include it so people can click on those and access that great resource. But we might have to steal the Ritter rules for surgery.
Isbell, spent the rest of his life, and he didn't know how long it was going to be, but helping his community, and that through those videos, it lives on. It's a beautiful thing. Tony, I see how much you loved him. I'm sorry for your loss with him.
Yeah, he was special, but it's very interesting, like what you just said, Amy, how many people he's helped, because
Oh yeah.
and like what you've done. I looked at that one of the videos, and it's been viewed 58,000 times.
It'll be viewed more now because we're about to put it on our website. And that's okay with his family, and they're all signed off on that and to share. Okay, wonderful. Thank you.
So we did have some questions. Dr. Estrera, if you're okay, I might throw some out at you. And I know we don't have a ton of time left. I know you're super busy, but not to put you on the spot, but I think you said you might be able to work out a little Q&A with us later. So for those who have questions in the queue, if we can't get to you today, we will get to you.
How much time do we have left?
Q&A. Well, we have about 5 minutes left in the hour. I don't know. I assume, I know Dr. Estrera, I'm sure, is incredibly busy, so I'm sure you have a very important appointment or schedule to get to after this. So I don't want to keep
I want to keep him past it. Do you have time, Tony?
Yeah, I'm okay. I got a few minutes.
Okay. Well, we'll keep going, and you give us a Hail Mary when you need
Hail Mary.
or a bow out. Okay, so one question that has come up, I hear it constantly, it's a huge source of confusion. Why isn't there just one number that's what when you have surgery? Some folks say, my doctor's telling me 5.5, but my brother says 5, or my friend says 5. Why do I have to wait to 5.5? Or why can't we just repair everyone and when they're at all dilated, and that way we can prevent every single dissection? Why is there not just one number? What is the source of discrepancy there? Because I think that is a huge source of confusion in patients.
I mean, that's a very good question. And I know you touched on this with Dr. Leftatis earlier. There's not one number because there's not just one person. That's the problem, is that everyone is different. And I think that's why it's so important, to have a conversation, with the patient and take all the factors, into consideration. We have to remember that surgery is very beneficial, but the reality is surgery is not without any complications. There is always that risk that even if it's less than 1%, it's not zero. And no physician can ever say to you that there is no chance that something bad will happen to you. You can never say that. And not knowing and not being able to predict the future, you have to be real careful because there are some patients who, are very high risk for surgery. But, most patients are, very good candidates and will benefit. And so I've always asked that question for the past 20 years is why are we still using diameter as the indicator for when we do surgery? We need better technology. We need better advancements to give us a better idea of when the actual aortic wall is now stressed. There's computer modeling. There's a number of groups that are working on identifying stress points within the aortic wall that might be able to predict when something might rupture, and then that's when you operate. A lot of the work that Dr. Milowitz has been doing with regards to identifying genes, you heard that story about Zoe and private right. I mean, they identified a specific gene that is very high risk to dissect, which then caused us to operate sooner. And I think this personalized medicine is going to come to the forefront. But that's why it's important for everyone listening on this webinar right now. If you have the opportunity to join into research studies, to be involved, the more data we have as researchers, the better conclusions we can draw with regards to making these recommendations, especially as it comes to the genetics and personalized medicine. But I know that's a long answer, for your question, but that's the reality. I mean, we need something better than just a diameter.
Yeah.
Doctor. The slide that you had up that had the FLAP, which is the individualized, like the surgery thing. So genetics would come under which one of those things? Because as you're oh, look, we're going back. Oh, good. I tried to draw a picture of it. Because as you are assessing like who gets surgery and who doesn't, and at what size, if you know, like Dr. Milowitz and people are working on, this specific family history, you have like the natural history of that specific gene mutation might dissect or become aneurysmal, dissect at a certain size, right? So if you know the gene, but if not, and you just know, so that would be life expectancy, anatomy. I mean, those are the general rules for surgery. But if somebody like John dissected, he was about to turn 55, and his brother Tom, who had an aneurysm, and at first it did not look like the size that would be operated on, but then Diana got into the mix and said, look, this might be really fast growing right before it dissects, because John's hadn't been, so all of that comes into play, right? The genetics, and even if you don't know the misspelling, the mutation of the gene, you might have just kind of an idea because of someone's actual family history.
Yeah, I think that's an important point, Amy. And in my mind, the genetics would fall into the pathology. So I like this flap because it makes me think of dissection, but I can call it flag if you want, FLAG, with genetics being at the end, which is true.
Don't patronize me, doctor. No, I was just like, when I'm going to be explaining this in human non-doctor terms. I didn't, because it wouldn't be life expectancy, but the pathology has to do with
genetics. The
genetics,
the pathology. So that's
like
where
flag.
in my mind that would fall in. So flag.
Okay.
That is a great segue. We have a question that I think is great because it's a practical, logistical question that people don't know how to get an answer to. And that is, someone commented, is it considered rude, or is it okay to ask your surgeon how many surgeries they've done, how many times they performed that surgery, with their success rate, or is that not something that they can give you an answer on?
Remember, as a patient, this is you. You have every right to ask any question you want. And remember, I had a slide in there. You have to feel comfortable, with your surgeon and your surgical team when you're getting a procedure. So that is absolutely not out of bounds in my mind. And in fact, I'll be honest, when I was very young, 20, 25 years ago, people would ask me, how many operations you did, and I would tell them the truth, and they hopefully would trust that I knew what I was doing. Now it's easy for me because I can say I've done thousands of operations, and that's not really as much of an issue. But I do think we all know as surgeons that the more experience you have with a procedure, the better results you're going to have. That's just in general. I mean, that's been demonstrated on a number of studies for all different kinds of operations. But I think what's important is the patient has to feel comfortable. And this is your body, your disease. You have to own it. And by owning it, you have to be very comfortable with the team that's going to be taking care of you. And so that is not out of bounds.
No, be proactive. Absolutely.
That's fantastic to hear. And I love the message. And I think that these patients are used to having to advocate for themselves. So they are experts on themselves, as you say. Okay, so let's see, what else do we have here? Okay, so some of these are just quick and practical ones. Are there any medications? I know you mentioned some antibiotics. Are there things that are specifically bad for people with certain genetic conditions, or is this kind of everyone with aortic disease?
Yeah, I keep it pretty general. And again, as you mentioned, we mentioned earlier about the fluoroquinolones. That's the one I talk about now. Dr. Scott Lemaire, who was at Baylor with Joe Caselli a few years ago, has really demonstrated that both in animals, and there are a number of other studies that have come out really supporting that, and it became a black box warning Remember, that's also the antibiotic that is associated with Achilles tendon rupture. So that's on the black box warning as well. And that all makes sense. It's all collagen. It's all connective tissue, and it affects the metabolism. So that's really the main one that we know about and we talk about now.
May I ask my Cipro question real quick?
Yeah.
You'll see this. It says brilliant ideas. These are brilliant ideas. My daughter Carly gave me this book, but interesting question. Cipro, stay away from it if you have an aneurysm or have had a dissection. Yes. If you have a genetic predisposition that you know about, or a syndromic or a syndrome that would, what about if you have like a suspected genetic, like the people in my family who know that it's genetic because of the family history, or a friend Meredith's family, but you don't have like the name of the gene and the stuff. Should you say to your doctor that Cipro is off the table for you if you're treating anything?
Yeah, I would say that. I would be very conservative. There are a lot of other antibiotics you can use. I mean, I had one patient.
I
had one patient who had some prostate issues, and all he could take is Cipro. And I said to him, "You can take it, but you just have to know that there is that increased risk." I mean, there's no direct evidence in humans. It's all population-based studies, and the direct evidence has been in animals. But I'm pretty conservative, and if there's enough evidence to suggest something, then I'll say don't use it. So
right. Okay, somebody stop clicking their pen. I hear you. I'm thinking Ellen.
Okay. So let's see, what else do we have here? Are those with aneurysms at risk of any side effects from the COVID vaccine or boosters?
That's a good question. I don't know of any increased risk related to either the vaccine or COVID infection as it relates to dissections and aneurysms. It appears that the COVID infection has something to do with the endothelium, of smaller vessels, and that's why you'll see clots and you see all these inflammatory changes in the lungs and the heart and things like that when people have COVID or long COVID syndrome, and it affects those folks. But remember, when we're talking about aneurysms, the issue is the middle layer of the wall of the aorta. So we call it medial degeneration, as opposed to the inner layer of the wall of the aorta, which is the endothelium. So they're really two different areas. And so I don't think it affects the medial layer. At least there's no evidence that I've been able to find. So
are we talking about COVID infection or vaccines? We're talking about COVID infection.
We're talking about COVID infection. And then, the vaccines, I'm not, I don't think there's any association with detrimental association with vaccine and aneurysms in general.
Okay.
Okay, great. Since you are a surgical expert, I'm going to pick some of these surgical questions out for you. So someone commented that they had a root repair, and they have now developed an proximal ascending aneurysm years later that seems to have grown quite a bit. Is this something that can happen, basically? What's the story here? If you've had your root repaired, do you have to worry about other disease? Similarly, someone asked if you've had your ascending or your root repaired, can you still have a dissection in the descending part of your aorta?
Unfortunately for both questions, yes. The thing about the aortic aneurysms in the section is, even though you replace a segment, there's always a risk for developing another aneurysm away from what you've replaced. That risk is, depending on the situation, may be low, but it's never zero. So if someone replaced the root, there's always that chance that the ascending or distal ascending or even arch can enlarge. I tend to be aggressive when we're going in there, and I know Dr. Leftaudis was talking about doing a total arch and ascending root. Depends on the situation. And but having said that, if there's any inkling that there's dilatation or disease in any segment that I'm operating on at that time, then I'll be a little more aggressive at replacing that segment to subject them to only one operation, if at best. I mean, that's sort of the goal. So unfortunately, those things can occur, and it really depends on, the situation. Now, if someone has a connective tissue disorder or some genetic predisposition, what Diana calls heritable thoracic aortic aneurysm section, then I'll tend to be a little more aggressive at resecting whatever I can resect at that time, so that we don't have to worry about it. I mean,
explain what resecting means.
I'm sorry, replacing. So when we resect an aneurysm, we actually take it out and then replace it with a piece of a new synthetic tube made out of polyester, Dacron.
Right.
Dr. Bakey made the first one in 60 years ago from a local fabric store.
Can I just ask, does resection, just because people are going to be talking to the doctors, they're going to be talking doctor talk, so does resection refer to the removing of it or the removing and replacing, like the whole procedure?
Yeah,
resection is taking out, right?
Yeah, taking out and then replacing it. So oftentimes in my note, I'll say resection and graft replacement. So some people won't necessarily resect the whole thing, but we tend to send it for pathology and genetic studies. So I like to get rid of it, and that's sort of what we've always done. But resecting means remove. You're right.
Got it. Okay. May I ask a question?
Yes.
Okay. In terms of a tear, not the surgery and then the possible aneurysmal or tearing effect, but a tear always tears downstream, and that has to do with the blood pressure and just the natural, how you're, like if you get a tear in between the layers in this part, it's going to tear down, right? And is that so it has to do with where it starts, how it's classified.
That's correct, and it's involvement, but 10% of those tears can go backwards, or what we call retrograde. So you can have a tear in the descending, and it can actually extend proximally towards the ascending.
Oh, because it goes into it and the blood pressure pushes it, so it bubbles out that way. Oh, okay. Here's the question then. Yeah. So here's the question. Let me see. How did I write this? Does, in terms of an aneurysm, what causes an aneurysm besides you have a faulty protein and a misspelling and all these things, and your smooth muscle tissue is a little screwy? Not a technical word. Does the tear that then bubbles out and gets filled with blood going someplace, it's getting displaced into the wrong thing, does that cause the aneurysm, or does the aneurysm cause a stretching of the inside that causes the tear? What comes first?
I think it can be both, but the second comment you made is probably more likely. What is happening is that you have the aneurysm, dilating, and then it makes the inner layers prone to tear.
Right.
And then
because it's like a balloon.
Right.
The other question is this: you said you're on trial now, and I've heard it said aneurysm. The reason that you want to treat an aneurysm is so it doesn't dissect and doesn't rupture, so you die. You don't have to have a rupture to die from a dissection, because if the blood, am I right? If the blood is not going where it needs to go, if it's getting caught in this kind of false tributary over here and not going to the rest of your body, you die, because your blood carries the oxygen and the stuff so you would literally die from not having enough blood other places. So it doesn't have to bleed out into your chest cavity and to pericardial. You can die just from it being lost inside of the lining, the blood being lost inside of the lining, correct?
That's correct. And what happens is more importantly, is when that dissection flap occurs within the aorta, which is that main pipe, you have all these important branches that come off.
Right, and it can block it.
That's exactly right. And now you're cutting the blood flow off to the brain, the heart, the kidneys, the intestines. We call that malperfusion syndrome when that happens.
Yeah, so perfusion is the blood going where it needs to perfuse to, so a sickness.
It's a flow of the blood is perfusion. That's right.
Okay. Ellen?
So we are at a quarter after, so I think we should let Dr. Estrera go now, especially since he's already volunteered to come back. He volunteered to come back to do more Q&A. Yeah, and Amy's got her cues for you, so be ready. But I really want to thank you, Dr. Estrera, for joining us and being such a great communicator with this very complicated topic. I think it can be hard for folks to get this information in a way that's digestible, especially when you're just learning a lot of these concepts for the first time. Maybe this is your first introduction to aortic disease. So we really, really appreciate you coming and communicating in such a wonderful way with us.
My pleasure. Today. And I do thank you, and Amy for the privilege, and honestly, all the work you guys do with the John Ritter Foundation is outstanding. And I truly mean that, Amy, that you have been very instrumental and probably one of the most important forces in increasing the awareness of this disastrous disease. So I thank you for that.
You're welcome. I love you, Tony. You started this whole thing. You explained it to me with a bar chart. I'm very visual. The more information, the more surgeries, the more lives saved. Got it. Message received. On to the 20th year pretty soon. Thank you, friend.
Thank you.
Yeah. So we'll end here, but as I said, this was recorded, so it will be available to view. If anyone missed it, you can send it to your friends and family, and we'll have a notice about the Q&A with Dr. Estrera soon to come, so you can join for that. I do have all the questions that were asked during this session, so don't fret. We are on them, and we'll be continuing to do these webinars for the rest of the year. So with that, thank you again to Dr. Estrera and everyone for joining us, of course, for participating.